We have a very distinguished guest, Dr. Mark Frye. So he was born and raised in Minnesota, and you were born at the Mayo Clinic, right? Where your dad was a surgeon, is that right? Cardiologist. So he was literally born at the Mayo Clinic. And I'm emphasizing that because he was the chair of psychiatry at the Mayo Clinic from 2010 to 2020. And he did his MD at the University of Minnesota, followed by residency at UCLA, and then fellowship at NIMH, focusing on bipolar disorder and treatment system. So we have that interest in common, bipolar disorder. Now he is a professor of individualized psychiatry, or individualized medicine rather. And but he continues to be an active researcher. He has the Mayo Clinic Individualized Medicine Biobank that they do genomic studies, and I think you're going to talk a little bit about that today, correct? Okay. And he also has grants from NIMH, and NIAAA, Mayo Foundation, close to 500 peer-reviewed publications. And he's received a number of awards, national awards in the area of mood disorders, the Jerry Clerman Award, that's from the American College of Psychiatry, the Depression Bipolar Alliance Award, and a number of ISBD, International Society of Bipolar Disorders Award, the Morgan Scout, that's for education, and the Robert Post, which is for mentoring. And he has been a mentor for a number of years at the Mayo Clinic, including a mentor of our own Javier Ortiz. He's also as I mentioned, continues to do research. There's another one, Breakthrough Discoveries. BD2 is a large-scale longitudinal study. I think you're going to also mention that study today. And then he's the scientific advisory chair of the Depression Bipolar Support Alliance. Now, the reason why he's here today, and I have known Dr. Frye for a number of years, we usually run into in meetings, but he was the mentor of Dr. Ortiz when Dr. Ortiz was a resident at the Mayo Clinic and continues to be his mentor. And one of the reasons for his visit, in addition to this lecture, is to see in what ways we can continue to collaborate, especially on the research of education. Now he's gonna share the podium with Dr. Ortiz, our very own Dr. Ortiz. We know he was born and raised in Guadalajara, attended the University of Guadalajara, followed by a residency psychiatry at the Mayo Clinic, and then a fellowship in community psychiatry at Yale, and now assistant professor at UCLA. So, Dr. Frye, and I'm gonna be leaving because I have something else to attend, but I did want to come and introduce.
Thank you very much.
Dr. Ortiz.
I'll take the spotlight for just 5 minutes. So, Professor Frye mentored me during my training, and I'm gonna talk a little bit about some work that we did together, and then I'll give the podium to Dr. Frye. These are the disclosures of Professor Frye. And so we're going to talk about the shared project that we have, which is using the Rochester Epidemiology Project. Really, the idea was to challenge or investigate whether the criterion dichotomy is still valid 125 years later. And then Dr. Frye will talk about his work in the NNDC, and we'll talk about health disparities in major depressive disorder and bipolar disorder. So the population cohorts in the United States are lacking, specifically because of the way the healthcare is structured in the United States, that there's all of these systems that are individual and fragmented, that they don't communicate with each other. Here we see that every day, in which we cannot get good access to the records of press. And so for decades, since 1966, in the area of southeastern Minnesota and some part of Wisconsin, there was this mission to link all of the records into one single database, so that will allow for really what I think is the only way to do geographical population-based studies in the United States. There's Kaiser Permanente claims that they are able to do that, but Kaiser Permanente is directly linked to the insurance status. And so the Rochester Epidemiology Project has had significant impact in medicine, but was little explored in psychiatry. The neurologists have done incredible work that has changed practice, and the rheumatologists. And so with the mentorship of Dr. Frye, I only wanted to do schizophrenia work, and Dr. Frye said, no, what are you doing? You gotta compare bipolar disorder and schizophrenia using this cohort. And so what we did, so this is the area, the geographical area in which we obtain most of the clinical records and get centralized. And so this is the team that we meet every Wednesday, and we have been producing some publications on this work. And so what we did was we first needed to find all of the first episode psychosis or first episode mania cases that existed since 1985 in that geographical area. That is done manually, compared to, like, if you will, are familiar with the Finnish or the Swedish databases, they do it using code. And so we reviewed each record manually and identified the first episode of psychosis and the first episode of mania. And then what we did was we went back to see what happened before the first episode. And what we found is that, different to what Kraepelin would say, was that there was already this temperament distinctions between bipolar cases and patients with schizophrenia. We found that they actually share more than they are different. We only found very minimal differences in the sex of the patients. Males were more common in schizophrenia, and immigration and race were more common. Race other than white were more common in schizophrenia. And depressive disorders and adjustment disorders were more present in depressive disorder. But almost all of the other clinical factors that we were investigating that could be extracted from a healthcare record were basically similar. So we challenged this assumption that based on antecedents, you can distinguish who will have bipolar disorder and schizophrenia. Some of the other work that we've done is distinguish, then we explore whether sex differences can inform or are different during the prodrome phase. We also find overlap with some differences that are outlined there, including, for instance, ADHD being more prevalent in males with bipolar disorder. And finally, so we published what happens before the first episode. We are now exploring what's happening after the first episode and following them through the next few years. The idea is that we will see some differences between bipolar disorder and schizophrenia separating themselves if the Kraepelian dichotomy stands. This is a work that I'm actually just presenting on Sunday at the schizophrenia conference. And it's just what I queried was, like all of the patients that get admitted involuntarily in the first year, treated involuntarily in Minnesota, there's a very different, probably a little bit more paternalistic way of treating involuntarily patients compared to New Mexico. If those patients, ideally, what we claim is that this is good for the patients, that we are taking their freedom away because this is the good for the patients. So the question was, does this actually impact functioning in the next 5 years, or does this impact time to relapse? And what we found is that it really doesn't. It seems that functioning in those that are involuntarily treated remains low, and the time to relapse seems to be the same. And so, those are the type of things that we have been able to explore with this project. And we just wanted to share a little bit of this, and I'll leave the stage to Professor Frye.
Thank you, Javier. So it really was an honor to mentor someone like Javier, really a critical thinker and just a great temperament and a wonderful team sort of clinician and researcher. But I want to go back and really underscore one of his points, because as we think about ways for UNM and Mayo Clinic to collaborate, thinking about other studies that we can think of with REP and how that might sort of look at a comparison group here in New Mexico. I'd be curious for the medical students or new learners, people like Rodrigo and I who've been around for a while, when we learned about sort of serious mental illness, there was this concept of Emil Kraepelin, who described schizophrenia, the older term was dementia praecox, that the onset of illness was very slow, very indolent, and emerged over a 2-year period of time with marked functional disability, where in fact, the same writings from over 150 years ago, the concept of manic depressive illness was absolutely fine until you weren't. And there was a rapid induction of symptoms that we now know is the hallmark of mania or bipolar disorder. And that dichotomy, as Javier was referencing, has been standard educational curriculum. My guess is probably 80 years or so. And so I think what's so remarkable about Javier's work is the concept of really challenging established ideas. There's every reason we can think of as to why the presentation of illness might be very different circa 2025 than 1895. Just think about concepts of genetic anticipation. Think about how much more accessible substance use is. I mean, there's lots of variables there, but we're hoping that we can continue the collaboration with Javier and more broadly with you here at UNM. So as Maurizio had said, I wanted to talk to you about a couple projects that we have within the National Network of Depression Centers. And my hat here is less about a Mayo clinician and more in the current leadership role that I have as the president of the national network. So for us to kind of just get on the same page very quickly, the most up-to-date data we have as a country or as a nation with regards to state of mental health is listed here. I'm not going to run through each detailed data point. Each of them by themselves are fairly staggering, and the composite would say that there is an enormous gap in optimal mental health care in this country. And I would leave you with the posit that one of the reasons this continues to be a problem is the last set of bullets. We have too few trained practitioners in mental health in general, mood disorders in particular. So my congratulations and my thank yous to the next generation clinicians who are here. We have not had enough research funding and not enough practitioners, not enough research funding. You can see where stigma can continue to linger. I think it's better now than where it was before, but we have much work to do. So I was really excited to have Mayo Clinic join the National Network of Depression Centers. And this really was the brainchild of Dr. John Greedon, who was the department chair of psychiatry at the University of Michigan. John really saw the power of a network, not taking away individual strengths of universities and what they can do by themselves, but coming together and asking what could 27 centers of excellence across this country do together that would be synergistically meaningful for the field, for our patients, to better educate people at the national or federal level who are making decisions regarding care and research. So I'm showing you the members that are here. I want to highlight we're missing one bullet because we just last year brought in the Autonomous University of Nuevo León in Monterrey, Mexico. So we are no longer one nation, we are a multinational network And we want to really see this grow. Depression has no international boundary. The symptoms are exactly the same. There certainly can be cultural nuances and influences, but to really highlight this as an example, when you look at the prevalence rate of bipolar type 1 disorder, that is a hallmark manic episode. It's 1%. Doesn't matter what country you're looking at. Now, when we look at rates of major depressive disorder and some of the cultural nuances, we get a little more spread, but we see value in bringing in Mexico. We see value in bringing in Spanish-speaking groups, and very proud to be representing this network. I'm not going to read the mission, but I want you to really understand the three main points here. We see ourselves as a network. We're not going to replace all the wonderful work that would be done, for example, at the University of New Mexico. What we would ask is, if we brought New Mexico on board with the entire network, what could we do as a group? How do we harness the power of 200 mood disorder specialists who will probably touch 400,000 mood disorder patients over the course of a year? We see our main mission is to transform lives of those living with mood disorders through innovation. And that innovation can be treatment, it can be prevention, but the goal would be a world that is free of stigma, where everyone has access to evidence-based effective mental health care. And there are challenges with that in every community in this country. Oops. So at one of our annual meetings, we have them each year, and we will be in Cincinnati in September of 2025. We wanted to kind of get a snapshot as to who everybody was. And if we start on the left part of the slide, we have about 375 faculty throughout the entire network who identify themselves as having expertise in mood disorders with funding. They have had some sort of research grant, whether it's an NIH grant or a small grant from their university. We have another 670, while they may not be researchers, they're very busy clinicians taking care of lots of patients struggling with mood disorders. And those 670 faculty, we think, see on estimate about 80,000 patients through their specialty clinics over the course of the network. And a very conservative estimate, if we start thinking about mood disorder experts or psychiatrists in primary care, I think you have a similar integrated behavioral health here. We suspect there's probably another 300,000 patients that have access to a national network of depression center clinician. When we asked our members to really say, when you think about NNDC, and again, not you at your university, but you as part of the network, what stands out? How do you really see what our core strengths are? And these should not surprise you, but it's a way of really getting a snapshot of who our network is. So as I had said, I'm honored to be our current president, but wanted to really recognize our executive board. We have individuals from all over the country, and specifically wanting to recognize our founding chair, Dr. John Greedon, and our immediate past president, Dr. Ray DiPaolo from Hopkins. I want to show you some of the work that the network is doing, and I am choosing projects that I think might have potential interest, or specifically, hopefully some collaborations with you all here. Our flagship program is what we call our Mood Outcomes Program. And this is our attempt to build a learning health system within the network itself. And this is where we are promoting a first and foremost measurement-based care, which I understand is here at the University of New Mexico. We would propose through our mood outcome program that the PHQ-9 and the GAD-7 and the Columbia Scale for Assessing Suicidality, that these are psychiatry vital signs. We want to track mood, anxiety, suicidality, and really understand that with large cohorts of patients. When you have data sets that are that big, you can start to see patterns that might not be clear with an individual patient or with a clinic. It sets the stage for quality improvement projects, and that's exactly how we see some of the first steps that we've taken with our mood outcomes program. So this data is uploaded from every site, and the Alterum Institute is a systems analyst group that maintains that data for us. But we see a day where we envision all of this data being collected that could be part of a dashboard where a patient and a provider could look at that together. So again, we emphasize the concept of measurement-based tools, setting the stage for quality improvement. And the mood outcome program, as you'll start to see, really has been the foundation for a lot of our task groups to then take advantage of and think about additional projects. So what I'm wanting to show you here is, as of calendar year 2024, we have 140,000 individuals involved in the network. Now, the collection is anywhere from 2016 to current day, but the sample size, we think, is very persuasive for thinking about larger scale studies. I wanted to give you an example, and this is a publication that has just been accepted, but it gives you kind of an idea of the power of something like a mood outcomes program. So in contrast to clinical trials, this is really real world clinical data. And we are collecting the patient's age, sex, race, ethnicity, measurements of depression, anxiety, suicidality. And we're simply looking at billing codes to clarify, do these symptoms differ when there is a bipolar diagnosis or a depressive disorder diagnosis? And we did a lot of baseline assessments and controlling for potential confounds, but the data that I wanted to show you is here. So as you can see, we've got about 48,000 participants in this data set, and this was probably from about 2 years ago when we started to lock it to analyze. And I'm showing you 36,000 individuals that have a depressive disorder diagnosis, and then about 8,400 that have a bipolar diagnosis. When we look at this data just on first glance and what we call an unadjusted analysis, we can actually see that the symptom burden for those with depression seems to be higher than those with bipolar disorder. Now, I should add, we're following people prospectively, and this makes sense to me because we know that episodes of depression in major depressive disorder are much longer than episodes of depression in bipolar illness. We did not see differences in suicidal ideation across diagnoses. We saw a greater number of suicide attempts in bipolar disorder. That again makes sense if you think that episodes of depression might be associated with episodes of suicide attempts, and in this case they are. But what caught our attention was the challenge of staying in a research study or staying in a longitudinal cohort. And single visits, what that really means is a patient that came into one of the sites, enrolled, did the baseline data, and we never saw them again. That's a failure. That's a dropout. And we generally assume that that is because of an enhanced symptom burden or perhaps a social determinant of health of how to access care on a more regular basis. So to see that single visit rate looked different by mood disorders caught our attention. And we wanted to even look at that a little more carefully in some different ways. So this is the journal focus. This is a new journal of the American Psychiatric Association. What I wanted to show you specifically here is some very important differences by race and ethnicity that we would like to try to better understand. And specifically, what we show in this subsection of our data is that individuals, African-American individuals living with depression or bipolar disorder had higher symptom burden on the PHQ and the GAD-7, but they also had greater likelihood of having just a single visit. So that concept of, are we doing the best we can to retain patients, participants in studies to better learn about the illness and to provide better care, this data would suggest that we have some work yet to do. And I'll circle back to the health disparity with one of our studies looking specifically at bipolar treatments. So just want to show you that sites that are involved in the mood outcome program, this data set is rich. This is a phenomenal opportunity for junior faculty to have mentoring at the national level, to have opportunities to really write scholarly papers focused on all sorts of types of ideas that can be generated out of such a large mood outcome data set like this. And this continues to be, this project in particular continues to be one of the greatest sources of scholarly publications for all of our network members. So as a former chair, where I had to kind of think about the merits of membership to the NNDC, the piece of membership that became very clear to me was absolutely invaluable. You couldn't put a price tag on it. Was really allowing and facilitating members to find like-minded people who had similar research or policy or clinical dilemmas, and really giving them an opportunity, a forum, a space to really think about collaborative projects. So the task groups that you see here are task groups where members said, you know, I've always kind of wondered about this, and what do you do at your site? Do you think we could put a grant in to better understand this? Or could we just look at variables together and have a larger sample size? And these task groups have flourished. You can see there's a good number of them. We are reforming the primary care telehealth community program. And in September, we'll be unveiling a new task group that's really focused on addiction and mood disorders. The secret here is that there are co-chairs and stakeholders really committed to the cause. And I wanted to highlight some of the work that some of these task groups are doing. Before I do that, I'll say that at all of our annual meetings, we really try to capture what we're doing right at these meetings and what needs to be better. I'm showing you some quotes from members from Hopkins and UT Health in Houston, Michigan State, University of Utah, and the theme is the same. They have recognized an amazing opportunity to join a network, perhaps have access to national thought leaders or clinical experts that may not be available on their campus, but they're available at the network at the ready. And having these task groups really provide opportunities for collaborating, whether it's a policy paper, a research grant, a clinical data set, has proven to really be impactful for their career. So what are some of these groups? So we as a network published a clinical trial looking at intravenous ketamine for treatment-resistant depression. It took us a little bit to get the study finished during COVID, and you can see that the primary paper is in 2024. And I'll tell you, point blank, our clinical trial is not going to be the most meaningful impact of the collaborative group and the study. We have 9 biomarkers that are analyzing in tandem right now, trying to better understand the mechanism of how ketamine was providing benefit. And I think that's probably where we will have great impact. But just to tell you a little bit about it, it was a 2-week study. And over the course of the 2 weeks, there were 3 ketamine infusions. This one is done at baseline. And the blood sample here is just to denote that there was a biomarker blood draw that was drawn and then stored before that first infusion. I understand there's a ketamine clinic here, and the kind of the field has developed a convention because this is such a rapid acting antidepressant. Most outcome measures really look at remission, not symptom reduction, but being symptom free the next morning. So if you have an infusion at 1 o'clock, we would have the patient come back the next morning, and that's where we would assess remission rates. Where we would assess remission rates. We have a second infusion that is within the first week, and then we offered a third infusion within the course of this 14-day clinical trial. Our overall remission rate by the end of 14 days, half of this group is no longer symptomatic of their illness. Think about that for a second. This is treatment-resistant depression. These individuals have failed a myriad of antidepressant pharmacotherapy, psychotherapy, some with TMS and or ECT. To see that symptom remission is remarkable, and it lines up with the rest of the historical data. But we were able to do some interesting calculations, and this, in my mind, really has clinical relevance. If you had a response after first infusion, you were more likely than not to have a full remission of symptoms at the end of the trial. What does that mean clinically? Someone who's having an early response, we can be encouraging of that. And it really would suggest that appears to be predictive of having a remission by the end. But the opposite is probably more relevant. A handful of patients remitted when in fact there was no evidence of response by first infusion, no evidence of remission by second infusion. So to turn that around, what the data is really suggesting is if you were not having substantial movement and symptom burden by first or second infusion, the likelihood that you're going to by number 3 is negligible. This is the type of clinical algorithm that is really important for busy ketamine clinics that might have challenges with access to slots and kind of figuring out how do we provide the best outcome measure for as many people as possible. These types of predictions of remission or non-response are important. We've also published a neurocognitive paper really showing that a very simple measure of neurocognition, the R bands, actually improved as depression got better. That might not be so surprising to most, but the reason we wanted to do that study is there was concern that repetitive ketamine might negatively impact cognition. So what we're actually showing is the safety of ketamine from a neurocognitive standpoint, and in fact, some patterns of improvement. Now, I really like this second study that the biomarkers task group did, and they followed these ketamine patients and found them after about a year and asked them their experiences of what they remember from that study. And even for people who did not remit, many of them saw benefit of previously having that ketamine trial. And the one that captured my attention, because we see this all the time, is someone who may not have had full remission, but they had symptom improvement enough where they could get rid of a benzo, or they could get rid of Buspar, or they felt like they were a little more functional at their job. To see that there can be these qualitative improvements was really encouraging for us to continue the work. Now, the reality is everybody in this study was a busy clinician. And in the context of this work, we thought we're learning together about how to really build a really efficient, patient-centered clinic. Why don't we write about our experiences? So in addition to the research, there's a publication from this group that if you were wanting to develop an IV ketamine clinic, here's how you would do it. Similarly, when we published this IV ketamine study, to our surprise, we had a number of insurance companies coming up to us to say, so you're doing this over intranasal S-ketamine. And we said, not necessarily at the exclusion of, but this has been, intravenous has been around for a long time. There's such methodologic studies to these works that we're actually finding that a number of insurance companies are improving the intravenous even when it wasn't to the same level as the intranasal. So the idea that our study captured the attention of insurance companies was a surprise, but I think an endorsement of the impact of what the network can do. I'm just showing you, and I'm not going to read them off, but I want to just really let you know how diversified the biomarker program is with this study. So we're not the most current publication, and we're certainly not the largest. But we have 75 participants that have 3 biomarker blood draws each, and we have a remission of 50%. You can start to see that from a statistics or analytic perspective, that seems to be very inviting to think about mechanisms of how ketamine might be helpful. And we have done all the conventional ones, the inflammatory markers, the insulin signaling, but you can see that we're getting into some pretty sophisticated genetic and mitochondrial analyses that I'm very anxious to see the results of. And the scientists and the investigators have the samples now, and these analyses are ongoing. Our bipolar task group really has been remarkable in a couple different ways. They were awarded a grant to do a pilot study looking at transcranial magnetic stimulation with the accelerated protocol for bipolar depression. Recall that TMS and a whole bunch of exciting novel treatments are being FDA approved for depression. None of them have development programs in the depressive phase of bipolar disorder. Let me repeat that so you can understand how frustrating that is. All these innovations that are really geared towards looking at major depressive disorder, there's no incentive to look at it at a different type of mood disorder, that being depression, when there is a history of mania or hypomania. And I know why. Studying the depressive phase of bipolar disorder is harder, because you not only have to look at the outcome measure of symptom reduction in depression, you have to make sure that getting better from a depression standpoint is not at the expense of getting manic. Does that make sense? That is hard to do. And I think it is challenging to do. And one person's opinion is, I think that seems to be an impediment for a number of potential strategies that could be really helpful. So that study was published in Journal of Affective Disorders. We currently are analyzing the merits of a patient-reported scale for mania called the PMQ. And we have a monthly meeting. If there's any new site that wants to build a bipolar clinic, they have access to all the clinicians and the administrators of the network who've already done so and can give them kind of best practices. Our Women in Mood Disorders is one of the most productive task groups that we have. I'm showing you a couple of the publications that they've had. They just were awarded a PCORI Engagement Award that is looking at how do we better understand addiction in women with depression, and specifically women of greater diversity of race and ethnicity. And this is a project I'm particularly proud of, because the investigator is a Mayo clinician, and they came to me asking about how do we think about engaging groups of women who are struggling with addiction. I said, well, one way is to look at women who are struggling with depression, because I guarantee you that addiction is going to be part of that problem, and that gets that whole concept of the dual diagnosis, or the addiction mood disorder comorbidity. Our neuromodulation group. So this is all the ECT docs and all the TMS researchers have come together. They have a number of publications that have really focused on expert consensus guidelines, a very specific letter to the editor, really referencing that while it is not a common treatment, ECT must remain a viable treatment for adolescents with treatment-resistant depression. And we have, being led by Peter Zandi at Hopkins, a large multi-site NIMH grant that's looking for genetic predictors of responding to ECT. Our child and adolescent group, very busy. They've taken a couple different paths that I think are very interesting, really getting some qualitative data from patients, providers, and parents as to what a cognitive battery should look like for non-adults. Also looking at the challenges of substance use and kind of the portal of entry, the impact of the portal of entry substance changing from alcohol, nicotine to cannabis. Some great work by this group. Our geriatric mood disorders group is starting to pull all the data sets that they have from each site. Can we try to standardize our neurocog testing? If there's a volumetric MRI, can we start to pull these together with rating scales for depression? A couple papers of theirs are scheduled to be published in our focus journal that will be on display at the APA meeting in Los Angeles next month. So social determinants of health has been a very strong interest for the group, and this has been hard to study. And I think the field is trying to figure out what are the best ways to do that. Are you all on an Epic electronic health record? What do you have? Cerner. Is there a way to kind of look for some of these determinants in the Cerner record, or not sure?
Theoretically.
Yeah.
It's not.
I understand what that answer means, so.
We are aiming to do it easy. We're aiming to standardize where we put it.
So it can be done. The problem is where do you store it, or where do you find it so everybody can see it really quickly? And that's a problem regardless of what the record is. But we sound, knowing that this is something we ultimately want to get to, we started to look at data sets that weren't part of our EHR, but we thought were important to kind of guide us a little bit. And what I'm showing you here is work of one of our postdocs who has returned to Monterrey, Mexico. This is Manuel Gardea Resendez. And our bipolar biobank, Maurizio had referenced that. We have a stressor questionnaire. We simply were curious how many of these stressor questionnaires might line up with the World Health Organization construct of social determinants of health. So what I'm showing you here in row A is the World Health Organization set of constructs related to social determinants of health. What I'm showing you in row B are actual questions from our stressor questionnaire that we think line up with this. And I think you will be impressed that they line up fairly well. And so we simply pulled out items from our stressor questionnaire and thought of them as surrogate markers of social determinants of health. And what we found is right here, this second bullet. When we looked at most illness markers of bipolar severity, rapid cycling, multiple hospitalizations, comorbid substance use, suicide attempts, there was unequivocally a significant relationship. The more determinants of health that were challenging, the more likely your illness was more severe, the more likely your illness was less likely to respond to treatment. And what we also found is that the valence, the different types of stressors, a positive stressor might be a job promotion, getting married. A negative stressor would be getting divorced or losing that job. That the valence of the stress seemed to differ by sex, and it seemed to differ by comorbidity profile. So as a network, we're thinking about data sets like this as to how they can inform a larger approach, whether it is Epic or Cerner, to start thinking about these determinants of health in a more meaningful way to better understand the illness and ultimately better provide greater personalized treatment for our patients. And Manuel's done a really nice job kind of thinking about determinants of health, medical comorbidities, functional impairment, chronic stress and accumulation, and how all of these feed off of each other. And so if we're really going to be focused on understanding one, we must understand all. And so as we go forward, we kind of have this concept of what are the determinants of health that we want to measure? What are medical comorbidities that we think can impact bipolar course of illness? There's many. We know that bipolar depressed patients, if they have a treatment response where they now are euthymic, whatever it is, if they have an obese BMI, they are going to have a faster rate to relapse than those who do not have an obese BMI. If they have evidence of inflammation, they're going to have higher rates of relapse than those who do not have evidence of inflammation. So the last topic, and then I will close, and Javier and I can entertain questions that you have. I'm showing you 3 postdocs that I have just immensely enjoyed working with. Javier, were you with Suleiman?
Yes.
Same year or
No, he was like 2-3 years ahead of me.
2 or 3 years ahead? Okay. As Maurizio had referenced, we have a bipolar biobank at Mayo Clinic, and part of that goal in building this resource was to have it be a repository to really look at DNA or other omic markers being associated with risk of illness or treatment response. And Margaret Atkin-Hami, who is now at the CDC, started to look at the bipolar biobanks, not only ours at Mayo, but 5 others throughout the United States and a couple in Europe, and had found very consistently that bipolar patients of African ancestry had low utilization or low enrollment in these types of research studies. There is a dark part of our history in this country with unethical research related to African Americans, and you don't need to think long and hard as to why that could be continuing to this day, contributing to low participation. But we saw that as a concern, and we saw that as a call to action to try to better understand the low rate of enrollment to see if we can change that. And it's an important story, and it's one that started to really shed light in a way that none of us had anticipated. So when Margaret finished her first paper, Suleiman El-Amin, Suleiman is also an artist, and this is one of his works. Suleiman started to look at data sets in the public domain and actually found that bipolar patients of African ancestry had different symptom endorsements than bipolar patients of European ancestry. Specifically, there were higher rates of psychosis and lower rates of core symptoms of elevated mood and energy. Now, the question is, how much of this was what I just told you versus a misperception of what the response was, and the rater or the clinician saying, well, that sounds
I
like,
was reading that, and I can go see.
I think that was an endorsement of agreement. So it started to sort of paint this picture where there may be symptom misattribution simply based by race. And that really lined up with what we see here. Now, if you don't have the right diagnosis, you're not going to have the right treatment options. So this is work of Monica Taylor-Desir, just published this year, where we looked at 4 data sets that really looked at lifetime exposure of lithium, mood stabilizing anticonvulsants, first generation antipsychotics, FGA, like haloperidol, and second generation antipsychotics, like all the ones that are approved for use. So the data sets I'm showing you here, the GAIN data set is from an NIH study some 25 years ago. Mayo Clinic data set, we've partnered with the University of Mississippi Medical Center, and then the NIH funded All of Us program. What I'm showing you and how to read this would be in comparison to bipolar patients of European ancestry, bipolar patients of African ancestry have significantly less exposure to lithium. They have significantly more exposure to second generation antipsychotics, and they have significantly more exposure to first generation antipsychotics, which we know carries a much greater risk for tardive dyskinesia. I find these data to be very sobering because these are data sets that really span 40 years. And I think our interest from a health disparity perspective is try to better understand why there's such differences in a gold standard treatment like lithium. And I don't think we understand all the reasons, but we're certainly starting to look at that going forward. Let me close and hopefully have some time for questions that I would like just to really emphasize that our network really sees the importance of critical conversations, whether they're local, at the university, at the state level, at the national level. And I think there's different work products that we as a network can accomplish based on which level that we're talking about. But I firmly believe that partnerships that are very respectful and very collaborative can absolutely design precision medicine initiatives going forward, where we can design better healthcare delivery practices for the patients that we serve, better understand and address health disparities, and absolutely educate a new generation or next generation mental health practitioners. This is kind of our goal, and in partnership with individuals with lived experience, really see just an incredibly bright future from the standpoint of how we innovate and prevent and develop novel treatments for mood disorders. So I've been lucky to have mentors along the way in many different places and wonderful colleagues at Mayo, and just wanted to recognize all of them here and thank you for your attention. So I think we've got about 10 minutes for questions and answers, and I might have Javier join me just to see how you're hearing all of this.
Thank you so much. What a wonderful talk. I was wondering if we could harken back to your biomarker work within the ketamine research. And so I'm thinking about that population specifically and sort of this idea of treatment-resistant depression. And I'm wondering if you could also sort of predict that some of those biomarkers may actually be more specific to treatment-resistant depression, in addition to like candidates for ketamine use. And I'm wondering if you're going to take the research that way.
So I think that's a great methodologic question. How much of what we're going to find is more suggestive of a biomarker of the illness as opposed to a biomarker of treatment response? Completely agree. I think it's going to depend on how you set up your analysis. So if we are saying, here is a group of patients that have TRD and remitted to ketamine versus TRD and did not, I think we can posit that that probably has something to do with treatment response, but it's not fully addressing kind of the baseline biology of the disease. And I think we have to start thinking about this more than we have. And if I can take your question and expand on it in a little bit of a different way, my mentor, Dick Wenchelbaum, has done a lot of work in the pharmacogenomics of breast cancer response, antidepressant response. And this is the sort of thing we're starting to recognize. And I can give you really concrete examples of this. We can do a genome-wide association study and see that a gene is associated with an illness. Well, what happens when separate studies are showing that same gene is a pharmacogenomic gene of a drug response for that very illness? So it's this, you're absolutely in this same space where we have to start thinking about whatever biomarker it is, we have to start thinking about the biomarker of the biomarker of response, but what it means in the context of the genetics or the biomarker of the illness, right? And it may be different for bipolar, unipolar, schizophrenia.
But and you could, I'm thinking about, I did some biomarker work with tuberculosis, very different, but I'm thinking like eventually you could envision sort of having a panel that both looks at treatment and sort of progression of illness to provide true precision medicine for a person's illness. Individual illness, yeah.
Completely agree. And I think a lot of our analytic questions going forward are going to think about an interaction. What is the biomarker as it relates to treatment response and the disease? And so a lot of our studies now are getting set up with what I call heterogeneous groups of depressed patients. We want BP1 depressed, BP2 depressed, unipolar depressed, dysthymic depressed, post-stroke depressed, getting the same treatments. And we simply look at, do the biomarkers delineate groups of differential outcome, perhaps having nothing to do with what the DSM diagnosis is, right? It's an exciting time to be doing biomarker research. It sounds like you have a recruit right there. Other thoughts, questions, comments?
Thank you both. It's a fantastic presentation, and this is an exciting network. Coming back to some of what Javier presented at the beginning, I'm thinking about these patients that present with kind of, their symptoms are still a little bit vague and diagnostically unclear, but we're appreciating that there probably is a prodrome with the decline in level of functioning, et cetera. And if I'm understanding this work correctly, you're saying that could be just as indicative of bipolar onset as schizophrenia onset.
Yes, so the move towards conceptualization of the prodrome as a transdiagnostic state instead of a specific trajectory that could really lead to differential outcomes. We see this. I mean, I've already seen a patient like that with Dr. Penrose today, where we are seeing symptoms of mania, sometimes there's symptoms of psychosis, and I still don't dare to declare if this is a specific illness. The only way, I think right now, without the use of biomarkers, is just longitudinal assessments, a la grappling way.
So any child psychiatrists here or kind of wannabe child psychiatrists? I'd love to have your input here. So what Javier is showing on the survival curves is we show that from time of first seeking treatment for any mental health symptom, anxiety, a positive tox screen, perhaps a neurodevelopmental delay. First visit, so treatment seeking for a symptom to time of incident case schizophrenia mania. So that's the time frame. It looks like it's about 8 or 9 years for both illnesses. So that concept of Kraepelinian dichotomy is gone. There's lots, and Javier can talk more about this. There's lots of things that are going on in that 8 or 9 years. There's a lot of substance use. There's a lot of prescription of antidepressants. There's a lot of stimulant use for some. But when I asked the child psychiatrists on our team to weigh into this, the answer I got continues to floor me. And their kind of answer was, am I doing something wrong? Is there something that our care model is doing that is in some way contributing to this illness trajectory? And I was not expecting that answer. And I have thought about it, and I think I've hopefully taken this clinician and had her think about it in a different way. What I see now with the dichotomy sort of basically not confirmed is we have 8 years where something is bubbling, and is there anything we can try to do from a phenomenology standpoint or a biomarker standpoint? I think you would agree if we see a bunch of activity for 6 or 7 years, but we can intervene to prevent a psychotic mania or a schizophrenia incident case, that's a win. So I kind of see that as, wow, how can we take this data and what other tools can we give clinicians that if we see these patterns, we say, you know what? I know you haven't had a manic episode yet, but this looks like the pattern where we are going to have one. Let's do more frequent monitoring. Maybe we empirically put on a medication. I know you haven't had a psychotic episode yet, but your pattern looks like you're going to. How do we think about intervening? I mean, you are in this space of early intervention programs. How can we take data like that and start to say, where do we put our early intervention efforts? What sort of patient? What sort of symptoms? What sort of early trajectory that's ominous, right? So I just had a patient in one of my studies. We had a research scan and he has a brain mass and it looks like, and he's 30, and it looks like it's probably a slow growing neoplasm and it's been doing so for about 15 years. But the neurosurgeon said, we can watch, but my worry is something that's going like this. So this is the growth pattern. I'm showing it's very slow. At one point might suddenly do this. I kind of see this the same way, is that if you have 8 years of this kind of noise, but it's telling us something from a prediction standpoint, we have a great opportunity for all the early intervention programs that Javier is going to develop. But I'd be curious, child providers, 8 years, what do you, I mean, so this is literally someone who is 12 years old and we're watching them until they're 20 and they have a first break mania or psychosis. What's your clinical experience say?
Thing I would say, in particular, is if a kid shows up with depression and they have a family history of bipolar disorder, don't give them an antidepressant alone, at least. I
Yeah,
mean,
yeah.
you know, that's, I've had a number of people like that who had their first manic episode after being given an antidepressant, when there was, I mean, there isn't always a family history of depression,
Yeah.
of manic depressive illness, but if there is, in particular, I've seen a number of cases
Yeah.
where there's a strong bipolar history and they could,
So,
you know.
no, I
it's
think this
ignored.
is, I think this is
It's
great. So we didn't have time to tell you, but when we looked at the use of antidepressants, it didn't accelerate time to mania.
ignored.
But we didn't look in the way that you're thinking clinically. We didn't look at those who were on antidepressants and those who we knew had a parent with bipolar disorder. So
Yeah.
that's absolutely something we can try to go back to.
Well, and the other thing is that if you get some sense that somebody's heading in a psychotic direction or again, has a family history of schizophrenia or bipolar disorder, perhaps doing whatever you can to prevent them from using cannabis or other substances of
Yeah.
abuse. I mean, whether you can do that or not, or whether you're gonna be
So
successful or
you're
not.
already starting to kind of profile
Yeah.
what interventions can be early or preventative in some way. No, excellent. Your thoughts?
I was one of the wannabes you asked for.
Okay. Got a great mentor right in front of you.
But I've had the opportunity this year to work with Dr. Ortiz in the early program. And I guess it seems as if this work kind of, it's based on the RAISE trial, which goes like far out of its way to exclude affective psychosis. And it seems like this might be sort of like, you know, we're leaving out a decent portion of the patients, maybe more inclusive access to these early programs that, you know, offer all kinds of interventions that can decrease stressors like acculturative stressors, employment stressors, education stressors, family stressors.
Before I arrived here, Dr. Lenroot did have the high risk, the Connect clinic, which was for all of these kids that seem to be on their way to develop a psychotic illness or a bipolar disorder. But yes, I mean, I think they have a little bit of a different intervention, but as you can see, we sometimes get patients that have never crossed full psychotic threshold or full mania threshold. They have like attenuated symptoms and they get into our clinics. And so the idea, I mean, with obviously having Professor Tobin is as a chair, we have a clinic that serves both, but many clinics for early intervention are exclusively dedicated to only psychosis, when in reality, as I see it, the illness is still undifferentiated at the first episode. They can still develop sometimes you go to the clinicians and they don't know, is there mania? Maybe a little bit. I mean, they were agitated and they were not sleeping. And so I am all for a transdiagnostic approach to the first episode, and only time will determine the differentiation.
So I'll remind you that he started his research wanting to do just schizophrenia and said, no. If you're coming into this project, you have to do both for the reasons that some are evident.
I have a question for Dr. Ortiz and Dr. Penrose, who I think is more well-read on this than he would like to admit. With a data set like this, one of the things that occurs to me where I went into is heterogeneous terminology and heterogeneous diagnoses for this prodromal period. Not many people used SMDD back in the day. It's not clear that it maps onto DMDD. Adam and I were discussing blips this last weekend. And it becomes a huge number of search terms to try and pull out that may or may not be describing the same thing. Are there ways around that?
It's in your methods.
Yeah, I mean, I think for the question for heterogeneity in concepts, I think clarity of, for instance, moving away completely from prodromes as a name, like calling prodromes, and moving into this concept of high risk, which include the blips diagnosis that you're referring to. the attenuated psychosis. I think it makes sense. I am not as well read on, and there's actually less work on bipolar prodrome. Bipolar prodrome and how does it present? There's no nomenclature for attenuated mania symptoms that can, start helping us track the trajectories in easier ways.
For this study, the first two authors, Javier and Manuel, went to every single case and reached consensus amongst the two that this is meeting DSM criteria for schizophrenia or for bipolar disorder. So would agree with your comment, and that's the problem with EHR data is it's noisy and it's not clear. So it depends on the research question you want to try to ask. And for something like this, where you want that granularity, just go back and make sure we have consensus that experts in the field agree that's schizophrenia, that's bipolar, that's neither. I don't know what that one is.
Thank you both.
Hello, thank you for the awesome presentation. I had a kind of a different question. Is there any fears of changes to the research or jeopardizing the research because of all the political change or the way funding has been distributed? Because this is important work, it's multiple institutions from different places. I'm just curious if there's already been changes to the way the research had to be done that may affect results in the future and things like that.
So I think this is charted territory, to be sure, and I think everyone's watching things very carefully. I think personally, I really have sort of my practice guide, what I think is important. And if, as one example, I showed you Monica and Suleiman and Margaret's work. I mean, I really came to that space with a different set of experiences, a different set of scientific questions. What I like about that and what I think is why it's such a good example is we came to the center of it with a mutual understanding where we really started in different points of a circle. And I think that's the best type of research that is informative, collaborative, and ultimately, as a clinician, making an impact and providing better care for all the patients that we serve. Well, thank you for the invitation to join you. It's been a great hour. Best of luck to you all.